Hello, welcome back to the channel. Today we discuss the DEMOULE trial, neurally adjusted ventilator assisted as an alternative to the pressure support ventilation in adult. This is published in Intensive Grade Medicine in 2016 November. My name is Dr. Buddhubhushan Borade. You can follow me on MediTalk by Dr. Bhushan and MediTalk by Dr. Bhushan on YouTube.
Disclaimer: the content of information on this video is for education purpose only and is not intended to be recommendation of any kind of sum whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this study. The intubated patient recovering from the acute respiratory failure plus neurally adjusted ventilator assisted NAVA compared to the pressure support mode PSV lead to fewer patients returning to the assisted ventilation. How does the NAVA compare to the PSV? What is the NAVA? Neurally adjusted ventilator assisted. It is an adaptive ventilation mode. It adjusts the level of mobility suited depending on the patient. That can be electro diagram signal. What DE is it? It is important that you are not adjusting standard but well enough in the general your EDD. You must know the top and expectation in the middle top point. What is the PSV? Pressure support ventilation with the partial support and mechanical ventilation. It develops a different level of extra pressure when the ventilator uses PSV. Use your words like a reader. Your reader. Pay attention to your reaction. Feeling the doubts question rise these to the author. Which was better, NAVA versus PSV? Background. As a patient becomes more stable, it is more practice to move from the assist control ventilation mode to partial support ventilation mode. Assist control ventilation VSV by Mascot. Synchronized EMV by Hamilton or IPPV by Drager, partial support ventilation by SIMV, PSV or CPAP or ASB by Drager. New adaptive ventilation modes are becoming available, which may improve the patient comfort and reduce the duration of ventilation. Adaptive support ventilation by Hamilton, NAVA by Mankett or proportional pressure support by Drager. Prior to this trial, NAVA had been tested in small and single center studies only. Design for this study. This is a randomized control trial, multi-center, log randomization started by center. Orientation measurement was achieved by clinician in number in velocity not united but all line patient and percent calculation of patient assumption of 30, 78 of patient will remain partially related to pressure support during the first 48 hours. Setting for this study is 11 ICU instance compared to 6 medical ICU for medical surgical ICU, 1 surgical ICU, 2,000 for this study. Population inclusion criteria: patient receiving ventilation for more than 24 hours for acute respiratory failure, including the NOVA method, clinic respiratory failure, acute cardiac edema, acute non-chronic respiratory failure. Meeting the following criteria: ability to sustain pressure support for at least 30 minutes with respiratory pressure below 30 cm of water, estimated remaining duration of mechanical ventilation more than 48 hours, level of sedation at most 4 on the Ramsey scale, absence of medical decision to increase the level of sedation, fraction of inspired oxygen of 5 to at most 50%, positive in inspiratory pressure P not greater than 8 cm of water, not an high dose of vasopressor therapy defined as a non-epinephrine above the 0.3 microgram per kg per minute or dopamine above the 10 microgram per kg per minute. Inclusion criteria: age less than 18 hours, known pregnancy, participation in another trial within 30 days preceding completion of eligibility criteria, contradiction to placement of NAVA is sufficient to any contradiction to placement of gastric tube or reposition of tube already in place. Recent gastrointestinal rupture of esophageal varices with a gastrointestinal bleeding during the 4 days of prior decision decision to withhold life-sustaining treatment. 3,896 patients screened, 128 randomized primary outcome available for 118 patient, cost of follow-up. Baseline characters nearly match in terms of age, fast forward duration of mechanical ventilation, prior to ventilation, cause of respiratory, significant baseline difference in terms of meter distribution, comprehensive hour target for higher intervention, neurally adjusting ventilator system ideal body weight. Management common to both groups. ED nasogastric catheter replacing one patient prior to randomization. ED monitoring data were available to clinician for patient with both groups. Criteria for switching to assist control mechanical ventilation. Failing partial support ventilation, respiratory distress, hypoxemia, hypercapnic acidosis, despite the optimization of ventilator setting, severe hypotension, shock or arrhythmias, increased need of sedation, agitation, patient ventilator including investigation or procedure. If criteria for partial support ventilation were restored, patient remained in some allocated treatment arm. Now our pressure support were restored. Patient were screened for medium extubation daily. The following criteria were with spontaneous breathing trial for 1 hour TPs, pressure support for 7 centimeter water with 0 p. Once conducted, patient were extubated if this was successful. Improvement in positive pathology. Outcome, primary outcome, proportion of patients who remained continuously in partial ventilation following inclusion of the extubation without any medical versus was not different. 67.2 in amount of 60.2 pressure support group. Due to misrelation of trend, secondary outcome you can read this more significant difference. Strength for this study was the randomized control trial multi-center equation with the statistical analysis. Primary outcome to not a very patient important outcome. Although there was significant difference in use of post-extubation non-invasive ventilation, there are no clearly defined guidelines regarding use of post-extubation therapy. It was left to the discretion of physicians who were unblinded. Although there were significant differences, it was synchronous between the two groups. Data